Hey everyone. Thank you so much, Vicky, for your intro there. My name is Shane Hebel, and as was mentioned, I'm the director of product for UrSure. Apologies for the technical difficulties. I think we're all still learning how to conduct these virtually over Zoom, but I think that you guys can now see our slide deck. Let me know if I need to make any changes there. We're very excited to be here and chatting with you guys today about adherence monitoring. I'm going to kick us off and kind of give you the high-level overview of adherence monitoring from our perspective, the UrSure perspective, and kind of walk you through our work to date, how we got started in adherence monitoring, some of the data that we've been able to collect so far. And then I'm going to kick it over to my colleague Harlan, who's going to go into the case study and the work that we've been doing in collaboration with FIGHT, how that has been going, best practices, what's working, what's not working. And finally, we'll just end things off with Q&A, and we're happy to answer any questions that you guys have. Alrighty, so adherence monitoring. When we think about PrEP, we think about three key things that really matter for someone to be successfully taking PrEP or HIV prevention medication, whether it is a Truvada regimen, a Descovy regimen, or even some of the newer regimens that we're starting to get data back for, like injectables, and a little further down the line, implants, and all of that good stuff. Those three components are uptake, adherence, and retention. We think about these three components as being like a three-legged stool. If you're missing even one leg of the stool, even one of these three components, the stool falls over and the program doesn't work. We think of uptake as getting people on PrEP. We think of adherence as people staying on PrEP and taking their regimen as directed, whether it is a daily regimen or an intermittent regimen, and taking that kind of in the way that they are supposed to. And we think of retention a little differently, as whether someone is persisting on PrEP over time. So this is more, are people showing up for their follow-up visits? Are they staying on PrEP through times that they are at higher risk? If they are going off PrEP, are they doing that in consultation with their clinicians and their healthcare team, and really thinking through whether or not they are in a season of risk, or if they're at a reduced risk, in a reduced risk environment where PrEP is no longer an option that makes sense for them, and kind of doing that all very intentionally. We may not be probably isn't a surprise for many of you. We see a huge discrepancy in PrEP uptake when we split out PrEP uptake by different demographics. What we've done here is we've just kind of put side by side and butted up against each other HIV incidence rates and PrEP uptake as split out by race and ethnicity, as you can see in these three categories. The light yellow bars on the left are new HIV infections. The dark, not yellow, blue bars, and the dark blue bars are PrEP uptake. As you can see, we see with white populations, lower HIV infection rates, very high PrEP uptake rates, and we see the opposite trend taking place in communities of color, people who are Black or African American, or people who are Hispanic or Latinx. This isn't the way that we should be doing PrEP uptake. We should really be focusing on the communities that need PrEP the most. And PrEP success really depends on us being able to get PrEP into the communities that need it most, and for those communities to be able to adhere and persist on that PrEP once they have it. What we're going to focus on today are these two pieces, the adherence and retention pieces. There is, as many of you know, the Ending the HIV Epidemic, which is a massive federal initiative to curb HIV infections in this country. That initiative has a very large focus on uptake, especially within traditionally marginalized communities, which is awesome, and PrEP should be in those communities more and more as we kind of move forward. What we are focusing on is not that piece, not getting people on PrEP, but once they're on PrEP, how do they navigate their healthcare systems in such a way that PrEP works for them? And what we've seen is that adherence monitoring has applications for both maintaining adherence on PrEP, but also maintaining retention on PrEP. And I'm going to walk you guys through a little bit of that data as we go along. First, a little bit of how we got started. This company, UrSure, actually was founded out of Philadelphia Fight and the PrEP program there. In that program, there were patients who were coming in who were getting PrEP, with a large number of those patients being Black MSM or men who have sex with men and transgender women. This is one such story of an individual who was on PrEP through the Philadelphia Fight program. Michael, obviously not his real name, was a patient in that program who was on PrEP, was coming in, was saying that they were adherent to their medication, but in one of their follow-up visits, their clinicians found that that person had seroconverted, and this person became infected with HIV at the age of 24. What I think was extremely frustrating about this and examples like this that I'm sure many of you have also seen within your daily practices is that these sorts of patients were just so close to a healthcare system that worked for them. They had navigated any sort of insurance barriers. They had navigated getting to a facility that was steeped in expertise around HIV and PrEP. They had that bottle of pills in their hand, and yet there are still barriers past that point that can prevent someone from taking their medication on a consistent basis. And that's kind of what we saw here. Digging into it, one of the key problems that we saw was that individuals were coming in, they were talking to their clinicians at their follow-up visits about their adherence to PrEP, and they were saying that they were adherent. There are a whole host of reasons why people do this. Sometimes they are adherent. Sometimes they have some sort of bias around wanting to please their clinician, recall biases where they just don't remember if they've taken their medication. There is a lot of systemic racism and stigma that afflicts these populations in the way that they navigate healthcare systems. And we've seen that that is a very big discrepancy. There are a number of patients out there who are going into their clinicians. They're saying that they're adherent even when they're not. And what that does from the clinician perspective or the PrEP navigator or caseworker perspective is that then you don't know who is actually adherent, who's non-adherent, and you can't allocate your resources effectively to say, hey, these are the people who are really struggling here and who have barriers, whether those barriers are as simple as, I have crazy mornings and I just don't have a system in place, all the way through to things like unstable housing, substance use issues, insurance issues, and things that are more systemic. But if there isn't a conversation and knowledge that that person is struggling, there isn't really an opportunity to brainstorm and find solutions. And that's really what we wanted to do. What we found through our research is this wasn't just a anecdotal problem that we were seeing in one clinic at one time. It actually expands out to the national level. There was a study done by a woman, Lisa Eden, where she went and she surveyed individuals at Black Pride events around the country for 5 years, amassed a data set of about 4,000 participants, and she asked these participants if they were on PrEP. And then she also gave them all a rapid HIV test. And what she found was really surprising. She found that HIV prevalence in Black MSM was about 60% higher for those on PrEP versus those not on PrEP. And that was kind of the opposite of what we were expecting her to find, because PrEP has extremely high levels of efficacy. If you're taking a daily dose of PrEP, it has a 99% efficacy rate for preventing HIV in that individual. So you would expect the HIV incidence rates to be lower within those populations. But what Dr. Eden found was that individuals who were on PrEP, they were engaging in higher risk behaviors, and they were also they would also start taking PrEP, but then either their adherence or their retention would lag. And this was kind of attributed to a problem with adherence and retention of kind of PrEP taking behaviors within those populations, as opposed to a problem with the drug itself. And this is the problem that we were trying to solve. We've seen that play out in other research and work as well. This is a graph from a study that was done by the Kaiser Permanente group in California, where they looked at their patient population who had ever had any sort of interaction with the healthcare system related to PrEP. So people were divided into three groups. One, people who a clinician had seen them and said, we think that you should be on PrEP, but that individual declined and decided not to take PrEP. Individuals who took that clinician up on that offer and got on PrEP and stayed on PrEP, and then individuals who got on PrEP but then were lost to follow-up. They were not retained. And what they found was also interesting. The HIV incidence rate per 100 people years for people who had never even been on PrEP was about 1.1 people. For people on PrEP, they didn't see a single HIV seroconversion within their population. It was about 1,000 people who were involved in this study. But for those who are not retained on PrEP, that incidence rate was 1.3 seroconversions per 100 people years. So it's actually higher than for people who had never been on PrEP in the first place. And for us, this really underscored the importance of not just making sure that people were adherent on PrEP for the times when they were coming in for their visits, but also seeing if there were ways that we could impact retention on PrEP as well, and make sure that if people are going off PrEP, it's done in a deliberate and thoughtful way that actually corresponds with their levels of risk in their lives at that moment, as opposed to as a result of their barriers that they were facing that didn't necessarily put them at a lower risk of contracting HIV if they did decide to go off of PrEP. So what do we do about it? We developed urine-based tenofovir tests, which are tests that can detect the level of tenofovir, one of the metabolites of both the Truvada and Descovy PrEP drugs, in people's urine. We did a ton of pharmacokinetic analyses that essentially gave us a sense of how much tenofovir we would expect to be in someone's system at various time points since their last dose. And what this allowed us to do is to develop tests where we can have indications such as, we know this individual has not taken a dose in at least 48 hours. We know that this individual has not taken a dose in at least 7 days, and things like that, that are kind of meant to act as a red flag for a provider or someone else on the healthcare team to say, hey, this person seems like they're starting to struggle. I may want to intervene at this point and have a conversation, see what the barriers are to their adherence, and kind of brainstorm with them around what those solutions are. We've seen that these tests anecdotally have had two kind of big effects. The first is that providers can give targeted support. As I mentioned, providers can kind of see which patients are struggling, and with their very limited limited time in the clinic on a typical clinic day, which is extremely busy and you're running back and forth all day, they can say, hey, I know that these are the patients who need me to spend that extra 5 minutes, and kind of allocate their resources appropriately to the people who need the most support. And the second thing that we've seen anecdotally, which has been really fascinating, is that patients have really liked seeing drug in their system. They've enjoyed seeing the test results and seeing that there is a tenofovir level in their system. One thing that is hard mentally about taking preventative medication, as many people on this call probably know, is that the outcome that you're going for is literally no outcome. If you're taking your drug the way that you are supposed to, nothing happens. So how we see that kind of play out over time is that people start off on a medication like PrEP, extremely motivated, taking their medication consistently, but over time, there's no real positive enforcement. There aren't really, for the vast majority of people, there are low to minimal side effects, so you don't really get a sense that this pill is doing anything at all. And you're hopefully not seroconverting and contracting HIV. So the lack of any sort of positive reinforcement can be mentally challenging, and we see adherence wane over time as a result of that. And what we've seen is that patients have enjoyed seeing that there is a tenofovir level in their system that they can see with their own eyes. And we've seen that that has a little bit of a motivating effect in keeping people adherent and in care. The way that we designed these tests was to kind of do them in a way that impacted the current clinical workflow of the clinics that we work with as minimally as possible. Obviously, there's no way to do this completely seamlessly, but what we've done is we've created first a lab test where an aliquot of urine is put into a cup that we provide, it goes to our lab, and the tenofovir results come back to the clinician through a portal. One thing nice about using urine and using that sort of test is that when people are coming in for their prep visits, they're giving a urine sample anyways for an STI panel. And the way that we've generally worked with our clinics, and I think Harlan will speak more to this a little later on, is that what happens on the back end is that a sample, part of the sample that the patient already provided for their STI panel is then sent to our lab. So from a patient perspective, there's no additional visits, there's no additional no additional samples that they need to give, all of that good stuff, which hopefully provides a more seamless experience. Once someone has that non-adherent result, that they haven't taken a dose in at least a couple days, over here I've just shown, we see that in about 20% of individuals. That number obviously fluctuates by any factor that you can imagine, by clinic, by geography, by time of year, by demographic. But on average, about 20% of individuals that we test at a clinical site are non-adherent. They haven't taken a dose in at least 48 hours. What we recommend kind of as a baseline structure is to do targeted counseling, which is sharing results, discussing adherence barriers, and brainstorming solutions with that individual. This can be as simple as the individual saying, hey, I just have super busy mornings and I just forget as I'm running around. And the solution that gets brainstormed is, let's set a daily alarm on your phone, or let's switch your pill-taking behavior from the morning to the evening when you have more time, all the way through to someone talking about having unstable housing, a substance use issue, insurance issues, which are harder to kind of brainstorm solutions to in that moment, but does allow that person to be connected with the resources that they need in order to navigate whatever that issue is. This framework has been tested out in the research setting. This 50% increase is from a study that was done by Revea Miko and Ray Fulanovitz at a site in California, where they did basically this. They would track people for non-adherence. When they saw that non-adherent result, they would do targeted counseling. And what they saw was a 50% increase in adherence over time. And that 50% increase for those people who were non-adherent persisted throughout the rest of their study as well. So we kind of replicated that within our clinical practice. So far, we have implemented this sort of testing at about 30 centers around the US and several centers internationally who are using a point of care version of our test that's in prototype form in a research setting. We've run about 7,000 samples to date. And as I mentioned, about 20% of those samples had not taken a dose of PrEP in the previous 48 hours. You can see at the bottom of the screen here a number of the sites that we work with, and of course, Philadelphia Fight there as well. One of the really nice things about kind of collecting data in this format is that we're able to, on the back end, analyze that data and see, is this program actually working? Something that I personally think is extremely important is that what we are kind of giving to clinics and what clinics are doing is effective, and it drives outcomes in a data-driven way. And having this number of samples gives us a really nice end to be able to look at trends in adherence across different clinics. And I'm going to share some of those trends with you guys now for what we're seeing for the outcomes of this sort of technology. So first I mentioned that we see about 20% of individuals that are non-adherent. One thing that has been really interesting about that is when we look at the concordance between self-reported adherence, so just asking your patients, hey, are you taking your pill every day? Are you taking it as prescribed? Having those sorts of questions. Most patients answer yes. My favorite kind of analogy to this is when you go to the dentist. I know for myself, my dentist always asks me if I floss every day, and I always say yes, regardless of whether or not that has been the trend since my last dentist visit. And we see the same thing across any sort of chronic medication. What we found here was, I think, particularly interesting. We looked at all of the patients who tested as non-adherent using our test for a biomarker for tenofovir levels, and had concluded that that individual had not taken a dose in at least 48 hours. And then we went and looked at what all of those patients said when they were in the room with their clinician. And what we found was that 4 out of 5 patients identified as non-adherent in those urine tests had self-reported daily adherence. So what this means is, let's say that you have 5 patients who are non-adherent in your panel of patients. 4 of them are telling you that they're adherent. What this kind of underscored for us was the need for this sort of technology, whether or not it's us or some other sort of adherence technology that allows you to identify who these individuals are. Because as it stands right now, they either can't remember what their pill taking habits are, or they don't feel comfortable having that sort of conversation with their clinician in the room without it being kind of broached and brought up by their clinician. So that's what we've seen. About 4 in 5 patients who are testing non-adherent with these tests are self-reporting that they are adherent to their clinician, which we thought was extremely interesting. We've kind of taken this data and we've plotted it over time as well. So we can look at for people who are non-adherent in that visit and then get some sort of intervention from their clinician, what happens to them? Do they go on to become adherent? Do they stay non-adherent? Is all of this for nothing? And this is a chart of kind of what we've seen. Here, what we've done is we've plotted the results by visit, so what visit number that individual is at, and then seeing what happened to those individuals over time in terms of their adherence status. And what you can see here is for people who are non-adherent, in our sample set, we had about 836 people in this sample set who had come in for more than 2 visits, so we could actually track what was happening to them over time. 87% of those individuals were non-adherent. And when they came back for that second visit, 72 of those 87, but 83% were adherent in that second visit. There were a couple of people who stayed non-adherent, and we tracked that again to a third visit. One thing you'll see that's interesting, I think, in this third visit is the N is a lot lower than what you see for visits 1 and 2. And the reason for this is that this is a real-time data set that we work with every day across our clinics. So the reason that this number is lower here right now is because the other 400 something people are literally right now between visits, they're out there living their lives. They're in this kind of white space down here. And as they come in, we can update this and see exactly what that adherence looked like over time. What we're seeing so far is things seem to be trending in the direction of persistence. You can see of those 72 people, 34 have come back in, 28 of those people are still adherent, 6 are non-adherent, again, as defined as no dose in the last 48 hours. And you can also see those persistence trends in the population who was adherent. You can see the majority of individuals stayed adherent, and then of those in the 409 who came in for their third visit already, 309 of those individuals have maintained their adherence. I think that this is particularly interesting because I think it shows how adherence kind of ebbs and flows over time for individuals, and how PrEP might not be right for some individuals. If we go back down here, it seems like there were a number of people who, an intervention was helpful, and that intervention did lead to increased adherence. And there are some individuals, particularly these 3 down here, where at this point they've come in for three PrEP visits. They have been non-adherent all 3 times. They've had at least 2 interventions, 1 here and 1 here, and it's not working. These individuals are still non-adherent. They are still not taking their prescription as they should be. And so even for me, this is good knowledge for a clinician to have, because you know that this person is struggling a lot. Maybe the conversation is about how do we make you become more adherent, or maybe the conversation is, this is not a HIV prevention strategy that seems to be working in this case. Let's talk about other strategies, whether it is thinking about your partners, thinking about using condoms, thinking about other things that could lead to less risky behavior as opposed to PrEP. Which, as we know, is just not an option for everyone and isn't right for everybody. And so this kind of gives you that data that allows you to see that. We've kind of also looked at these trends that we have over time and bumped them up against other studies that have been done on adherence out in the world. And what we've seen has been pretty promising, with the big caveat that ours is kind of a messy implementation science sort of data set, and the others are a lot more rigorous in terms of their study design. What we have seen is that when we look at PrEP visits at the clinic level, over time, we see a little bit of an increase in PrEP adherence over time for groups who have implemented these tests. So we started out at about 82% adherence for a clinic, and over time, that increases very, very slightly. Whereas what we've seen in other studies that we've analyzed using the same kind of methodology as the way that we've analyzed our data is that we do see declines in adherence over time. Now, these data sets include everyone, people who are adherent and who are non-adherent. This to us is kind of initial preliminary data that suggests that that positive feedback loop that you get from kind of seeing tenofovir results in your system is having some sort of impact. And we're seeing that those people are maintaining their adherence to PrEP a little longer. But the next kind of step to this sort of analysis is we want to go back and we want to do this a lot more rigorously and kind of figure out kind of what's driving these differences that we're seeing within these different populations. Finally, I mentioned retention as a key piece. Another interesting thing that we've found is that individuals who are non-adherent using the biomarker tests are much more likely to drop out of care over the next 6 months as the people who are testing as adherent and having higher levels of tenofovir in their system. This was an analysis that we did where we looked at dropping out of care over the 6 months after a PrEP visit. And what we found was about 20% of individuals who had tested as having high levels of tenofovir in their system as being adherent, about 20% of them dropped out of care over the next 6 months. Whereas when we looked at the non-adherent folks, the people who hadn't taken a dose in at least 48 hours, about 35% of them dropped out of care over the next 6 months. And we started working with different groups to kind of see if there are ways to incorporate this into clinical practice and say, hey, you know, if your patient is non-adherent to PrEP, that's a good indicator that that person has an increased risk of dropping out of care over the next 6 months. So whatever retention retention interventions a clinic might be using, this may be a sign that that individual who tested non-adherent is someone who you should, doubly make sure that you're calling the day before their appointment, or doubly make sure that they're getting resources through whatever retention interventions that you're using to make sure that those individuals are coming back into care. We've also seen that increasing someone's adherence can have an impact on their retention. What you see here on the right-hand side is people who came in for 2 visits. So for people who came in and were adherent for 2 visits in a row, we saw about 12% of those individuals dropped out in the 6 months after their second visit. But here on the right is what we thought was most interesting. For people who were non-adherent and got some sort of intervention and then became adherent in that next visit, those 72 people that I was talking about before, only 15% of them dropped out of care over the next 6 months, which to me is a pretty far cry from this 35% that you see for people who only had that non-adherent result. And so what this kind of suggests to us is that if you can work with a patient to get them to a state of adherence, what that leads to over time is for them to maintain care for longer, and their rate of non-retention drops to very close to the level of someone who is adherent the whole way through. This is the last thing I want to share with you guys, and then I will turn it over to Harlan. One piece of this that we wanted to be very careful about and do a lot of work on was acceptability of these sorts of tests from patients. One question that I get every time I do a talk like this, and I imagine will come up today as well, is this feels like a drug test. It feels like you are testing someone for a drug, and there's like a gotcha moment when it's revealed that someone said that they were adherent and they're not adherent, and does that erode the trust and relationship that a patient and provider has? That is something that we want to be extremely cognizant of, and that I've spent a lot of time looking into across our different clinical sites to see if that was actually the case. And what we found was that this actually was not something that a lot of patients were super concerned about. It is a large concern for providers. And we see that providers, every time we do a survey, every time we have one of these, providers are asking, is this like a drug test? How do I navigate that piece of it? But what we found is that the patients have appreciated getting these tests. We did a survey, actually also out of Philadelphia Fight, where about 90% of PrEP patients thought that a urine test measuring adherence would be helpful. There was a similar study done with an adherence blood test in a population in Kazakhstan who very similarly felt that it would be helpful and a bonus. And we've also seen patients kind of see it as something that providers are doing that is going the extra mile. We've done a couple of surveys with a group down in Houston with the Houston Health Department, and individuals have said that doing this sort of testing to the patient actually indicates that the clinician cares more about them and their personhood and everything else going on in their lives. We've had groups say that it's really kind of bringing these adherence conversations more to the forefront and allowing patients to have those conversations. And once they see that their providers are not, being judgmental about their lack of insurance or their drug use, that kind of opens up the door for even more conversations. And I've included a couple quotes on here as well that we've seen that I thought were particularly striking, I think, for me. The first being that this patient had said, I know I had told you that I had been taking the PrEP every day, but I actually hadn't started taking it yet. I'm glad you called. I'm taking it every day now. So this patient had said to their provider, I'm taking the drug. The urine test came back as though they weren't. And when the provider called, they were able to have a conversation about it. Second, kind of going back to that positive feedback loop, we had an individual who said that they're really trying to remember to take their PrEP every day, and they're happy that the test is showing that that's working and that they're seeing a level of tenofovir in their system. And this is kind of getting at that positive feedback loop and a positive reinforcement for individuals, and almost like a thumbs up or a good job to an individual who has been trying really hard to take their PrEP, and this is kind of an external validation of their effort and their work. So that is the high level piece of this presentation. Happy to answer any questions that you guys have about any of this data or any of the work that we're doing towards the end in our Q&A. But for now, I will turn it over to Harlan, who's going to kind of discuss the use case at Philadelphia Fight, how it's going, best practices, all of that good stuff. So thanks so much. And Harlan, I will pass it over to you.
Thanks, Shane. Hi guys, I'm Harlan, and I'm going to talk about Philadelphia Fight's PrEP program and the urine tenofovir testing. So we first I'm going to go over basically the program, how it starts. When a patient comes in, we of course do an HIV test, make sure that this patient is negative. We review the medication, so that's Truvada, Descovy, side effects. Then we have a discussion about adherence and what that means for the patient. Trying to get them to think about taking their medication as part of their daily routines and incorporating that so they don't have any missed doses. All right, let's see, next slide. And though also we reviewed every 3 months, come in and get your baselines done, what those tests entail. So that is, of course, an HIV test, that is an STI test, and the metabolic panel. Okay. So developing an adherence plan is really something that you do with the patient and provider. It's a group effort, but it's more so the patient who is in charge of it. They're running it. We're just kind of like guiding them through it. We do a risk assessment of their sexual health, sexual risk. They identify some things that they want to work on or some things that they need to change. And we decide what that plan looks like for them, what they decide, and I just help them. All right. Incorporating into daily routine, we discussed that, okay. So as part of my job, I try to make it as easy as possible for the patient to stay adherent to their medication. That is, I'll call them once a week, once a month, if I need to, just to check in. We have daily texts that we can send out to patients. We also have a support group that meets once a month. Right now it's meeting every other week due to COVID, making sure everyone's adherent. And then we identify their local pharmacy if they need to pick up from us, if they need to pick up get it delivered to them, whatever issues we may have with that. And we schedule them their follow-ups. Okay. Next slide, please. And then, okay. So patient comes in every 3 months for their baselines. During that time, we also will take urine for the chlamydia, gonorrhea, urine test, chlamydia, gonorrhea urine test, and we'll take a piece of our small sample of that urine for the urine tenofovir test, adherence test. Then about 8 to 10 days later, after we ship that out to the lab, we'll get the results back and we'll have a discussion with the patient on whether or not they were adherent. Most of the times, and luckily for me, the patients I've worked with have been adherent. The ones who haven't, they have enjoyed, seeing the results, and I guess knowing that we are monitoring, we're actually really monitoring it. It's not just a discussion, it's not just a talk. We're not just talking to them, but we're actually keeping track of these things, and we have data that we can show them themselves. Like, this is the last time you took your medication, or this is the time frame we think that you took your medication. Sorry, guys. And then we go from there. So we continue to do that every 3 months, and hopefully the patient stays adherent. If they don't, if their retention goes down, we can also see what other factors are going on in their lives that contribute to that. So the last slide I have is just basic information that we have from our PrEP program here at FIGHT. So the number of patients who had at least one urine tenofovir test was 269. And this is over the last year, I believe. The number of patients who had more than one test, 132. And the number of patients who received the urine tenofovir test was 74. So overall, 82% adherence has been what we've seen in our program with patients. And yeah, we're just going to keep improving the program. I know that UrSure is working on different technologies and things like that. So we will answer, I guess I'll answer any questions. I don't really have any more to say. My part will be. So I'll turn it back over to Shane. Oops, sorry.
Thanks, Harlan. And yeah, I would say that kind of wraps up all of the information that we wanted to share with you guys. And at this point, happy to take any questions that you guys have and chat about anything that's on your minds related to our presentation on this topic. So thank you, everyone.
Thank you so much, Harlan and Shane. For everyone who's in the audience right now, if you have any questions, just type them in the Q&A box that's under the PowerPoint that's being shared right now. One question I actually have is around with just kind of adherence. Have you had any issues with people who are taking multiple medications that have different schedules, and how that's kind of related to barriers and how that's dealt with?
Not so much. Most patients just will incorporate their PrEP medication with their other medications. They'll take it around the same time.
So thank you.
Yeah, no problem.
Yeah, I would also add to that, one thing that we've seen that has been really interesting has been when people are taking multiple medications, there's kind of the scheduling problems if someone is on regimens that need to be taken different times. But we've also seen that there's also sometimes kind of confusion about like which pills to take, and people sometimes don't even realize what medication that they are taking. Um, so we had one case where an individual was going into their clinician for PrEP visits, and they were really insisting that they were adherent, they were taking their medication every day, and our tests just kept coming back as absolutely like no tenofovir in their system at all. And eventually this clinician decided to ask the patient to bring in the pill bottle. And the individual had been taking a medication that looked pretty much exactly like a Truvada pill. It was another blue pill that they thought was Truvada and wasn't. And so the clinician was able to talk to that individual and kind of have a conversation about making sure that they were taking the right medication. Which is another thing that we've seen, is that there's been a lot of kind of clarity over making sure that people are taking exactly the right medication, and it kind of broke down that barrier of, you know, the patient was just saying, yes, I am taking a blue pill, and and that would have been the end of it if we weren't able to kind of test for drug metabolites in the person's system.
Interesting. Cool. Thank you. So we have a few questions coming in. One person says, is there a significant difference in the adherence based on age?
There is. We've kind of done a number of analyses across different demographics. I didn't put a slide in here. What we've seen at a high level is that people who are younger struggle more with adherence. We see the highest levels of non-adherence in populations under the age of 25, which is probably not a surprise to anyone on this call. And we see that kind of trend up gradually, almost pretty much in like the way that you would expect as people get older. And we see that older populations, especially populations over 50, generally have the lowest levels of non-adherence. Harlan, I don't know if you've seen anything kind of from the fight perspective on that.
I definitely agree with you. Since I work with the adolescent patients here at Fight, they do have the biggest adherence issues, and they need the most support. So coming up with creative ways to keep them adherent, to remind them to take their medication, is my daily job. And yeah, and I know our other prep coordinator, Terrence, who has the adults, not as much of the adherence issue with them, and because they're goal centered, they know what they're doing. Then that's it.
Thank you.
Yeah, I'm just, I'll just bring people back to the slide for a second. One of the groups I saw on the slide, this red line here, was a population from the Adolescent Trial Network. As you can see, their adherence kind of started the worst and got worse from there. And that was a population under the age of 24, which I would say is representative of what we've seen of that population as well.
Yeah. So next question. So do you guys work with any pharmacies that help coordinate PrEP and other medications with patients?
We do not do a ton of work with pharmacies. The kind of one area that pharmacies have been interested in what we're doing is really around the retention piece and kind of seeing, well, I guess I would say two things. One is this an intervention that will increase retention on PrEP so that people are coming back and getting more refills of their medication? And the second piece that they've been particularly interested in is like, what is the concordance that you see between biomarkers of adherence and refills and refill counts? And are refills a good measure of adherence? What we've seen when we've done those sorts of analyses is that refill data also, it's better than self-reported data when it comes to measuring a patient's adherence, but it's still not great, because what we would typically see is that someone will come in and get their refill, and then that bottle just like sits in their vanity cabinet or on their shelf at home, and they don't actually take the pills. So that's been an area that pharmacies have been particularly interested in. Harlan, I think you would be able to speak better to me in terms of coordination with other meds.
So we work with all pharmacies, whatever pharmacy the patient prefers. We'll work with them, and I call them to make sure the patient's medication is ready for them. I call to make sure their insurance is up to date, and really don't have that many issues with pharmacies. It's more so the insurance companies are the bigger issue with dealing with PrEP and making sure that the patient gets it.
Thank you. So if anyone else has any other questions, feel free to start putting them into the Q&A box. I mean, I guess I'll just say, just to comment on everything, I really enjoyed this presentation just generally. It's really, I think it's like interesting to think about all the factors that really can play into adherence, and like the importance of kind of getting at those points and troubleshooting might be the wrong word, but like working with the patient in order to break down barriers. Just is really important work, and it's really interesting to see not only the data but also see to hear Harlan's experience working at FIGHT specifically. So I really thank both of you guys for providing such a comprehensive and really interesting webinar on this. All right, I think we have a question.
Thank you so much.
No problem.
So did you notice that adherence issues followed national trends when it comes to race?
Do you mean in terms of kind of like the demographic breakdown that we see nationally, or issues of race that we are seeing, especially right now in this country?
She
yes,
said,
okay.
yeah, she means the demographics, yeah.
I would say kind of, I didn't put a lot of the breakdowns into this presentation, but nationally what we are seeing is we see higher non-adherence rates along exactly the demographics that you would expect to see higher non-adherence rates, which is kind of depressing to say, but that's kind of what we've seen nationally. One thing that has been interesting, or I guess two things that have been really interesting about that data. First is that there's a ton of variation in that. There are some clinics that we work with where when we do that breakdown of different demographics, especially race, there's no difference in levels of adherence between individuals of different races or ethnicities. And there are other clinics that we work with where we just see vast disparities. And when you average them all out, you see some disparities. But it seems like it is a lot more of a clinic by clinic story than it is one that we can kind of have a narrative for on a national level. The second thing that we've seen that has been really interesting to me has been that the interventions seem to work regardless of whatever demographic group you are part of. So when we look at, let me go back to this slide here. When we look at this 87%, we have a higher number than this now with across all our different clinics. But if you break this down into different races and ethnicities, and then you look at the number of people who became adherent afterwards, you see high levels of change in adherence, regardless of the demographic. You see about an 80% improvement in adherence within a population, regardless of that race or ethnicity, which to me is kind of indicative that, you know, this sort of targeted counseling is specific enough and can be tailored enough to each individual that it fits their needs, and there isn't really a we're not seeing deficiencies with this kind of like overarching counseling tool in different races or ethnicities, which has been, I think, great to see.
Thank you. So another question is, are there plans for targeted research on PrEP for cisgender women or for transgender individuals?
I love this question. We presented an abstract at the Women in HIV workshop that preceded CROI earlier this year, where we were looking at differences between adherence for across every gender combination that individuals could have, whether it was transgender men, women, cis men, women, and then people who identify as non-binary and other areas across the spectrum. We had a pretty low N for that, but what we did see was that there was a fairly large disparity. We see that rate of about 20% non-adherence. That's mostly driven in this data set by cisgender men who have sex with men. just because that's the population that most clinics are serving right now. But when we would look at cisgender women and trans women, we would see non-adherence rates that were significantly higher, usually in the 40 to 50% non-adherence range. We recently kind of took that data and expanded it out, and actually literally yesterday submitted an abstract where we looked at adherence trends across different genders across 6 of our clinics. So we had a much higher N. We had, I think, about 500 people in that analysis. And we saw a similar trend. We see higher rates of non-adherence for cisgender women, about 50 to 70% higher than for cisgender men. Our data suggests that individuals who are women who are transgender and men who are transgender have higher levels of non-adherence, but the ends that we have that kind of suggest that are still pretty small. And one of the things that we've been talking to a number of our clinics about is kind of, the lack of representation of those populations as like large numbers of PrEP programs all across the country is something that we're super focused on and want to improve because we can't really make any sort of claims around adherence with populations of like 5 or 10 people at these various clinics. So we're really keeping an eye on those numbers and seeing how they trend up over time, just so we can kind of do more research and have more conversations around those populations. But we do see higher non-adherence within female identifying populations, either transgender or cisgender.
Thank you. Another question is, have you seen differences in, oh, I think this is the same question.
Same question, yeah.
Yeah. All right. So if anyone else has any other questions, feel free to put it into the Q&A box. We can give, I guess, everyone a few more minutes to think of some questions to answer. But just generally, thank you again for the webinar. And after we get off, just to everyone who's watching, just make sure to fill out the post-event survey. Okay, so if no one else has any questions, Harlan or Shane, do you guys have any closing statements or anything you would like to say before we kind of end off? I know we're ending a little early.
No, I don't think I have anything else to say.
Yeah.
But if you have any questions, you can find my information on the Philadelphia Fight website. And you can email me directly, and I'll be happy to answer any questions you guys have.
Yeah, it's the same here. Thank you so much, everyone, for kind of giving us this opportunity to present what we're doing to you guys. And similarly, all my info is online. If anyone has any additional questions or wants to chat more about this, feel free to email me. Happy to continue the conversation and keep chatting with people.
Well, thank you so much, both Shane and Harlan, for this. And thank you, everyone, for showing up and being here for our last session. And I hope everyone has a great rest of the day and rest of the week. All right, bye.
Bye.